Good afternoon and welcome to our webinar with Mr. Steve Melek. This webinar is hosted by the Office of Integrated Healthcare Research and Policy in the Department of Family Medicine at the University of Colorado School of Medicine. Before introducing Mr. Steve Melek, I would like to quickly go over a few housekeeping items for GoToWebinar. As you can see, you will view your control panel on the right-hand side of your screen, and on the left hand will be the viewer for which you'll view the slideshow. If you are interested in asking questions throughout the webinar, instead of waiting till the end, you can submit your questions through chat. At the end of the webinar, we'll do a Q&A session, and you can either raise your hand and I will unmute you, or if you submit your questions through chat, I will read those to Mr. Melek and he can answer through there. And you can connect through the telephone or your computer, mic, and speaker if you're having difficulties hearing us. Today we are pleased to bring you Mr. Steve Melek. Steve is a principal and consulting actuary with the Denver Health Practice of Milliman. He joined the firm in 1990. Steve's area of expertise include healthcare product development, management, and financial analyses. He has worked extensively in the behavioral healthcare specialty field. He has worked with many managed behavioral healthcare organizations, parity issues and cost analyses, mental health utilization and cost in primary care settings, psychotropic drug treatment patterns, and strategic behavioral healthcare systems design. He has experience with plan design, pricing, capitation, and risk analysis, provider reimbursement analysis and strategies, healthcare revenue distribution, and utilization management analysis. He has completed valuation and projections of healthcare businesses and product lines, profitability and experience analysis, reinsurance analysis, pricing model and strategy development, and actuarial liability determination. Steve has advised HMOs, PPOs, managed care organizations, behavioral healthcare firms and associations, insurance companies, employers, hospitals, physician groups, PHOs, and the state insurance companies. Today, Mr. Melek will review the need for payer data for this Colorado State Innovation Model. Welcome, Mr. Melek. And I'm going to pass the presentation over to you.
Thank you, Emma. Hello, everyone. You can use Steve for the rest of this discussion. Being informal is just great with me, and thank you for the opportunity to chat with everyone here about what's going on with the Colorado SIM model, why I'm involved, and why we need your help to put our best foot forward for this proposal that we're working on, and that's what we're here to discuss today. If anybody's having any audio problems or something, please raise your hand and chat with Emma. I will just proceed, assuming that although I can't see you, you can certainly hear me, and we can have an interesting little discussion at the end of this. And as Emma said, feel free to ask questions as we go along. I don't have a lot of slides. And forgive me if any of the slides I do show you are already information that you know, but I wasn't clear on the knowledge level of everybody on the phone. So I thought maybe we would start with a little background on the SIM project. Then I want to talk about what our proposed methodology is. And anything that I'm going to share with you today is subject to modification, discussion, review, change, etc. This is kind of where we're at right now, what the Milliman ask will be from the payers that are on the line, and talk about what our method's going to be, learn a little bit from what CMMI has told us in the round 2 awards for what I think of as local innovations and not a state innovation, although they are both related to CMMI. And then hopefully at the end some discussion, and we may not need the full hour, we shall see. So anyway, some background on the state innovation models that CMMI is providing up to $300 million to states that put forth good proposals for the residents of their entire state. And there's certainly a focus on the public sector CMS reimbursed programs, Medicare, Medicaid, CHIP, but they certainly have given us all indications that they really want us to add in the commercial payers and make the change that we're going to be suggesting and proposing something that will cover the lion's share of providers' patients. And 3 states received this pre-testing assistance, which, and these are my words, so if I get them wrong, Ben, Lorez, or somebody else certainly correct me. But my translation of what Colorado received was kind of a, that's an interesting idea that was proposed, oh, I don't know how many months ago. But they essentially said it's a good idea, but it's a little limiting. It's too focused on Medicaid. It's not quite statewide. So here's some money to go do it over, beef it up, make it broader, bring in other payers, and essentially do a version of a best and final offer. And they gave us some money, and they've given us 6 months, which really means we got to finish up our stuff in October to try to put our best foot forward. And why would we want to do that? Well, there's a lot of money on the table, and it's a great opportunity for the state of Colorado, like the governor wants us to be the healthiest state in America, to put forward a proposal to help advance that objective. And where maybe somebody else can talk about where we think we're going to land as far as how much money we're asking for. But if it's consistent with the 6 states, Oregon, Minnesota, and others that were funded after the first round, they're averaging about $40 million plus for the grant money over the period of their innovation. So we certainly have a lot at stake, and we expect to be in the same range. And I believe I've heard that CMMI is essentially told Colorado you need to get more than 80% of your population covered as part of this opportunity. That's why it's critical we bring in Medicare Advantage, commercial payers, et cetera, to include in our proposed model here. So our proposed model, I think you all know, is an integrated medical behavioral approach in primary care settings. Others can expand upon that, and it's being developed as we speak and will continue to be developed. But here is my proposal on the methodology that we would be doing to try to put our best foot forward. And it's kind of a projection, as many actuaries have done with innovations or with any sort of changes to our healthcare systems. What's the first thing you try to do? You try to project what would happen if you did nothing. What would our projected costs be across the state for all the different cohorts of people if we continue doing what we're doing today? So that's kind of our baseline projection over the contract period for CMS and CMMI to review. What's our baseline projection? What would business as usual look like? And to do that kind of projection, we really need historical data in detail. And I'm thinking 3 years of data will probably be sufficient. 2010, 2011, and 2012 from each of the cohorts that we're projecting for this proposal. And we'll develop a baseline period from probably the 2012 data, but we'll use the 2010, 11, and 12 data along with any sort of policy changes or other benefit design changes that are significant to develop trends within our historical data that we can use to project our business as usual scenario for the proposal. Now I'm thinking these projections are going to be by major healthcare service category, and I'll show you a little bit more about that, and as well by population cohort. So we'll be projecting commercial large group business separate from Medicare, and maybe Medicare fee-for-service separate from Medicare Advantage, Medicaid, separate by eligibility category, CHIP, those kinds of things. And we won't get every single member in the state. We probably are not going to do TRICARE, for example, or we'll have to think about what we want to do with the currently uninsured that will no longer be uninsured in the future after we go onto the exchanges and expand Medicaid. But we want to put our best foot forward here to try to tell a really good story for the state of Colorado to get this 30, 40, $50 million funding from CMMI to do a really interesting reform for a piece of our healthcare delivery system. And I think the concept is a really solid concept. Certainly the clinical folks on the line and others can talk about the potential value for good integration or collaborative care, whatever you want to call it. But to put our best foot forward, we want to try to tell a convincing story from the financial side as well as the clinical and operational side of things. And from the financial side, to do this kind of business as usual projection, we need these detailed data that I'm going to be talking about. And in the process of putting our business as usual projections together, we're also going to take those cohorts of utilization and cost elements and develop what I'm going to call change factors. Are we going to reduce inpatient admissions and days? Hopefully, yes. Are we going to reduce unnecessary emergency trips? Hopefully, yes. Are we going to reduce perhaps some unnecessary primary care symptomatic treatment of behavioral disorders? Hopefully, yes. Are we going to decrease specialty treatment of comorbid medical conditions because the patients are not taking good care of themselves because they have depression or alcohol problems? Hopefully, yes, all of those things. And they will be modeled as change factors. And then we will have a new scenario after we implement in a phased-in basis these changes, so that now we have a post-implementation scenario of costs, and we will be projecting savings for the program. Meanwhile, while we're projecting these savings, we are also, in a parallel fashion, develop what the payment reform models are going to be. And that's going to include paying for some of these services differently than we're paying for today. CMMI wants to see innovation in clinical, operational, and financial elements of healthcare. And I think that's why they would say you guys did a good job, is you addressed all of them. And we also have to be able to prove, and I'm taking other funded state models into consideration, as well as what CMMI is focusing on round 2 of the CMMI innovator proposals. It's really important to the federal payers that we achieve net savings during the course of the program, that this thing will be sustainable after the money goes away, because we've shown that we can bend the cost curve and save money and get people healthier, so that they feel like their model was the money was well spent, and we're also going to get an ROI after the funds go away, and that it's scalable, that we can show what we do in Colorado can be taken to other states that have not tried something like this, just like maybe we can learn from what they're doing in Oregon or what they're doing in Minnesota and other states that have already gotten SIM funds. So that's I'm going to stay at a pretty high level for things, and then we can dive in during the discussion as people want to. So that's kind of a high level flyby from the actuarial perspective of what we're doing as part of the SIM team. I wanted to show you the template, the financial template that's included, that's required for anybody doing individual CMMI proposals. And I know various groups across the state of Colorado and all across the nation are putting their best ideas forward, and there's probably going to be about 100 of these funded between $1 million and $30 million. they'll be announced in the months ahead, launched next April. But they're requiring you to use service categories like those you see here in the first column, and then for at least the CMMI individual proposals, that you can see the population cohorts that they've built into the model. And I think our proposal for the state of Colorado is going to be a bit more detailed than this, but this is just a template. And to go along with this template, they are asking for supporting information on how you got all these numbers. But this is just to give you a feel for what they're doing on a more local level, be it in maybe Grand Junction or maybe in Chicago or somewhere in Tennessee, wherever all these different models are going to be pitched. And I think less than 1 in 20 will ultimately get funded with the $900 million that CMMI has got set aside for these round 2 innovators. But this gives you a feel for the kinds of service categories that we would be using, and they actually may vary for the different patient populations because, as you all know, commercial coverage looks different than Medicaid, and it might be different than Medicare, et cetera, as to what are the most important service categories to use. But this is to give you an idea of what we'll be proposing and the kinds of actuarial analysis that we will be doing. So how do we get that data? Well, we need the payers to be able to either summarize their data for us or give us detailed data and let us dive into it. And that certainly is a much more flexible option because the model is evolving, and what we have today may not be what it looks like a month from now or 2 months from now. So that's why I am thinking that detailed data, detailed claim and membership data, it gives us the most flexibility to flesh out what our model is going to look like and put our best foot forward. Having said that, I don't think I want to see detailed data dumps from all the payers because getting multiple sets of 300 plus different data fields with detailed data dictionaries and the time it would take us to figure out how to use all that stuff and then how to combine it all together might be very, very time consuming, might be a clumsier way to try to do this. So here's what I'm proposing. I'm proposing something like this, some sort of a limited data extract from each of the payers that's going to look something like this, where we identify 15 or 20 key medical claims data elements that everybody can populate with your own queries and give it to us in some sort of a delimited file or an Excel file. Excel files are probably going to be too big, so it's probably some sort of a text file or data delimited file. Unique patient identifier, don't get too worried about that if it's going to be PHA or non-PHI scrambled number. We just need to be able to follow patients along for the multi-year period, because if the analysis is going to require identifying cohorts of patients with different disorders or different sort of, certainly eligibility criteria and other sorts of things that are going to be the focus of perhaps not the clinical models, although that certainly can vary by patient cohort and comorbidities or significant behavioral disorders, or wherever we land on what the detailed model is going to look like. And it could have different kinds of cohorts for different kinds of providers that want to participate in the payment reform. And I'm not suggesting it's going to look like Massachusetts, but they're a state that's put forward different levels of providers taking on different kinds of behavioral benefits in primary care settings and participating in payment model design also at different levels. So we're going to be continuing the discussion of what that looks like, but having this kind of detail gives us the ability to do very flexible analyses and tell a good story. So we'll need some kind of medical claim data extract. And if everybody can agree that this is the way to go, we will get this in front of you as quickly as possible so that we can continue to stay on track to complete this and do a really good job in time for submission in October. And that might sound like that's not much time. Well, we still have about 4 months to get stuff done, and it sure is a lot better than 4 weeks of the round two CMMI proposals that are due in the middle of August. We'll also have some sort of a prescription drug ask, and the fields are going to be a little bit different, but we very much want to include pharmacy data in here as part of the projections, as part of our analysis, because it's a very important piece of the reform that we're going to be proposing. And we might have more spend in some categories and hopefully more patient compliance with treatment regimens, and as well, perhaps less spending in some categories where we've not hit proper clinical, we've had suboptimal dosing by well-intentioned primary care providers, but for whatever reason, it just didn't work. And then, of course, there's always tricky issues like patient-resistant depression and things like that. So we will want a separate prescription drug claim extract as well. And then lastly, some sort of a membership extract. So we can certainly properly relate claims to membership, not include claims where membership fell off, or not have membership where we don't have claims, so that we're getting all of our PM costs aligned properly. And then if we've got focus on certain ages or focus on certain lines of business or certain eligibility types, we want the proper details to be able to pull that out of the data and again assemble our cohort analysis to the best of our abilities to tell the best story we can about the great innovations that we've got planned for the state of Colorado, and we can get the federal support to do this as we go forward in the years to come. So that is really a quick flyby of what our ask is for the payers that are on the phone. And now I want to turn it back over to Emma, and hopefully you can start asking questions of me or of others that are a part of the call here, and we can have some discussion on any things that you're confused by, concerns you have. I think I would like this to be as informal but as open as possible with folks on the phone. Thank you, Emma, for the opportunity again to give a brief presentation of what our actuarial analytical needs are for the payer so that we can do the best we can for this project.
Great, thank you very much, Steve. So before we get started on the Q&A session, I just want to quickly note that this webinar is being recorded, and the posting will be, the recording will be available on our YouTube channel, which you can see right here. So we do have a couple questions and a comment. So we'll start with the question: would the model show increases in spending in some of these categories along with positive change factors?
Absolutely. Yeah, we want to spend more money where that's the right thing to do. And you all probably have often heard that 20% of people with behavioral disorders get treatment from specialists, and the other 80% either get no treatment or they get some version of treatment in primary care settings. We're trying to help advance that, to give more people help, and those that are getting help that didn't get help perhaps in the best way, to get primary care docs more support. And I don't want to pretend to sound like I've got the clinical answers, but we definitely will be having the change factors increasing spending in areas where we really want to with our program, and of course to get those medical cost offsets and decreases in other higher cost areas. So this looks like a really smart investment and gets a return on investment.
Great. And we also have a comment for clarification, and that it's very important to understand that the CMI Round 2 and its related template is completely different from the SIM. CMMI Round 2 refers to the Innovation Challenge projects, not the state innovation models. While there is doubtless some congruence between the financial template required for the Innovation Channel project and the SIM, it is important that everyone understands these templates will not be the same.
That's correct. Yeah, I was just kind of using them to try to look behind the curtain a little bit on the sorts of things that we could learn from other things that CMMI is doing. But absolutely, that template is for our different purposes, and what we're going to be doing is separate from that. We'll develop our own service categories, our own cohorts. It will likely be more detailed than that template that I briefly showed you. And I don't think there are any limitations as to how we decide to do what we want to do, other than our own internal time constraints, data constraints, other sorts of things that just might limit how much we really can do.
Okay, our next question. Once you have some of these data, how long does it take to analyze? Is this dependent on how much data you receive? Just trying to get a sense of timing.
Well, that's a good question, and I hadn't thought in advance about that. But let's say through some magical actions, we got all the data we wanted in exactly the right format by August 1st. And that literally seems impossible. But I'm thinking to do what we want to do with a fair amount of attention from our firm on this, of course, working interactively with the SIM team, the SIM leadership. But this will be a significant focus of ours here, and we will probably do a lot of analysis within, I'll say, the first month of receiving the data, so that we can start putting together preliminary models for the entire team to react to, for people to look at our change factors, for people to look at projected returns on investment and patterns of savings. And after that, it will be an interactive work plan where we do scenario testing and sensitivity testing, and well, what if we change this part of the reform model, et cetera. So I think the first month will be get it all built, put it in place, and then we can start spending other time with looking at different scenarios and how do we create the best story.
All right. Should our data exclude Medicaid and CHP plus and only include costs from our commercial populations?
Well, that's a good question. And here's, I don't know if I have the exact right answer here. We are going to try to model every significant beneficiary and member cohort in the state of Colorado. I don't know if somebody else can, that's been closer to what did we learn in round one. And I think I've got the fact right that we were told you've got to cover at least 80% of the membership in the state of Colorado. So if that means we've got to put CHIP in as a cohort, Medicaid in as a cohort, or several cohorts by perhaps beneficiary type, commercial large group in. I don't know if we're going to try to put in small group and individual, and maybe I should know this, but I don't know how many members are included in the state for those cohorts. But certainly large group, Medicare, Medicare Advantage, Medicaid, and CHIP, I think are going to be necessary for us to cross that 80% threshold. I'm interested in other people's opinions on that.
Steve, would you like me to unmute everyone for a discussion about this?
Oh, I think that would be terrific,
Okay.
unless there was a reason not to.
Okay. So I'm just letting you all know you are now unmuted. Maybe not. Let me see. Um, I'm not sure if we can do that. Hey Ben, can you try saying something to see if we can hear you?
Yep, can you hear me now?
Yeah.
I think we're unmuted.
Yes.
That introduces all kinds of nice echoes. Is there any way that you can test unmute the people who raised their hand?
Okay, actually, I've muted everyone again because that was a little too much. So if you would like to say something, can you just raise your hand using the little icon on your controller panel, and then I will unmute you. Okay, Patrick Gordon, you are unmuted.
Hey, Steve, this is Patrick. I was just going to ask a logistical question since it seems like time is of the essence. Are you going to give out contact information so we can get actuarial and data warehouse people together with your folks and get working through the detail on this quickly? Or how do you want to kind of move forward with this?
I am happy to do that. First of all, can you hear me?
Yeah. Yeah.
Okay, my last slide included my phone and email address, but yes, I am happy to work one-to-one or in a group fashion with, I don't know if the best thing is to get a payer group together to work as fast as possible to get this data stuff figured out, or just one-to-one based on it's harder to schedule groups than individuals. So whatever works for you guys works for me.
Well, for us, just expediently, if it's you directly, Steve, I will just have our folks get in touch with you, and we'll get started. But if you find you need to do this in a group process, we're happy to go that route as well.
Okay, excellent. Thank you. So I would like to ask for any other reaction from payers. Is the approach of just giving us a defined data extract? I want to make sure that that's kind of well received, and yeah, that's doable. That'll work for us. That's much easier than comprehensive data dumps of warehouse data. I'd much rather have a concise set of data with the same fields from everybody. Is everybody okay with that? Maybe you can just send yeses to Emma or no's.
We have one yes.
That's better than zero.
And Patrick says, yes, Rocky thinks that this is best. And just a couple other comments. On behalf of the industry, probably yes, but we need to ask all the payers. Sounds good, doable. Look forward to connecting Steve directly with our actuarial folks.
Sounds good.
And that was, so the comment about on behalf of the industry was Ben Price with the Colorado Association of Health Plans. All right, and if that's all the questions that we have for Steve this afternoon, um, we will end our webinar now. And I just want to remind everyone that this webinar, the recording will be posted on the YouTube channel. And let me quickly just show that slide again so you can see our address. All right, well, thank you very much for joining. I hope you have a nice afternoon.
Thank you, Emma. Thanks, everyone.